Welcome everyone to our Indigenous Behavioral Health series. Apologies about starting at the event a little late. We had some technical issues here. If we were to be kicked out during the event, please just use the same link and get back in again if you can. But hopefully this will be uneventful from here on. Today is the first session in a series focused on crisis intervention. My name is Monica Dreyer-Rossi, and I am the program manager for the Indigenous Behavioral Health series. This four-session series will focus on common crisis situations. It provides an overview of crisis intervention guidelines and strategies, and describe clinical responses to common behavioral health emergencies and crisis in clinical practice. This session is presented to you by the National American Indian and Alaska Native PTTC and ATTC located at the University of Iowa. We are a part of a national network of technology transfer centers. If you would like, please put your name and where you are located in the chat so we know where you are calling in from. I want to thank Sarah Adams, our graduate student, for her support of the event today. Also, thank you to our director, Dr. Anne-Helene Skidstad. Next slide, please. This program is funded by SAMHSA. The content and opinions expressed during the session do not necessarily reflect the views and policies of our funder. Next slide, please. Please take a few moments to give us feedback on the event at the end of the presentation today. We will share a link to the evaluation in the chat. We will also send a follow-up email after the event with the link to our evaluation survey. Attached to that email, you will also find instructions about how to receive a certificate of participation. We will share additional resources in the follow-up email, but we cannot share the recording or full slide deck at this point. Please feel free to post your questions and comments in the chat throughout the session, and our presenters will try to comment as they can. And with that, I will leave it to our presenters, Dr. Winters and Dr. Gray.
Hello, everyone. I hope you're all having a great summer. Perhaps it's gone too fast. It has for me. Seems like summers go faster as the years move on. Perhaps that's just a phenomenon of getting older. I have been a consultant and enjoyed it immensely with the center for several years. I also am a senior scientist and a very active researcher at the Oregon Research Institute, but I'm based here in Minnesota and get to enjoy activities with the Oregon group long distance wise. I was at the University of Minnesota for several years, and all of my work is focused on behavioral health, a lot of it on adolescent or young adult health, but substance use and co-occurring disorders has been the major attention. It's a pleasure to have you here today.
And I'm Dr. Jacque Gray. I'm a Choctaw and Cherokee descendant and am the co-interim director of the National American Indian Alaska Native Prevention Technology Transfer Center at the University of Iowa School of Public Health. I am also a research professor emerita from the University of North Dakota School of Medicine and Health Sciences. And I work with a number of other programs around the country since I retired from the University of North Dakota, and have been involved with programs in Indian country for over 40 years. I've also worked with the Maori in New Zealand around suicide prevention. And, you know, I've been working with the center for a number of years, as Dr. Winters indicated he had, and worked with individual tribes and groups around crisis and suicide prevention for a number of years. So thank you. Next slide, please.
I can handle this, Jackie, just to introduce everyone to today's topic and a reminder of what is also part of this series. Crisis intervention is our main focus for the next several sessions that will occur over the next few weeks. As you may know, the center here has produced several series. We're going to look at various clinical oriented topics related to intervening with crises and emergencies, both clinical and individual client level, but also when we think of crises and emergencies in communities. Today's session, led by Dr. Gray, will provide an overview of some of the main issues when we think about addressing behavioral crises, and there'll be a focus on suicide. So you get to see one particular crisis type phenomenon, and it serves as a good model for how other crises can be addressed. And then we have additional sessions. They'll look at select clinical topics. Session 3 is case illustrations. And then, as is usual in our series, we end with a reflections and open discussion time. We hope you can join us for all of them, but each of them are relatively independent, so you'll find, I think, great value anytime you can join us. Today's session does have some interactive components. We have discussion questions that we hope you can weigh in on, either by unmuting or putting comments in a chat box. And then we have a word cloud type activity, so we can get some interesting feedback on where people are with certain topics and questions. It's a pleasure. I'll turn it over to Dr. Gray.
So I think we missed a slide somewhere, but anyway. Okay. So kind of an overview of what we're going to talk about as far as behavioral crises are some of the conceptual issues and the difference between behavioral emergencies and behavioral crises, the clinical response, and I'll focus on suicide with that, what a crisis team is and how it's utilized, and then a summary. Next slide, please. So some of the conceptual issues, first of all, a behavioral emergency. And that exists when the client is at imminent risk, either of behaving in a way, many times intentionally, that results in serious harm or death to themselves or others, or being a victim of a serious harm or death. And some of the most common: suicidality, the potential of violence to others. I know one example I'll use today. Here in Oklahoma, there was a shooting at a football game on Friday night. So those types of things and how it impacts the whole community. Situations of grave risk to a relatively defenseless victim, like a battered spouse or an abused child. And then states of varied impaired judgment where the individual is endangered. And it can be acute intoxication, substance abuse, but things that impair the judgment of an individual, so that puts them in danger. Next slide, please. So we'd like at this time for you to either share in the chat box or raise your hand and unmute yourself so we can call on you. How should you define imminent risk? What would that be? Anyone like to raise their hand? I know it takes a few seconds to be able to type things in. Threatening harm to self, danger to self or others, immediate risk of harm. Thank you, Matilda. And Dr. Winters has noted that right below that we have a definition by a researcher. Immediate access to lethal means, if the client is in danger to self or others, acting on the plan. So imminent really deals with at any moment. So right away, there's no, they walk out your door, they may do it right then, or they might do something in your office or wherever you happen to be meeting. And as Dr. Winters indicated from McCorney, in the clinician's opinion, there's a risk that the patient will harm or kill him or herself or others in the next few minutes, hours, or days. So it can vary that much from minutes to hours to days. And I think with some of these emergencies that have happened as far as school shootings and community shootings, there have been indicators and people have reported, but then there wasn't anything that could seem to have been able to be done. That's because if they aren't indicating that they're going to do something immediately when you have them face to face, it's really hard to prove that they are. So it's hard to put an emergency hold on a person if you can't prove that. So how does a clinician form that opinion of the likelihood of imminent risk based on available evidence known about the individual client? So if they aren't telling you that they're going to do this in any minute, how do you form that opinion? Any ideas? Raise your hand, unmute yourself, type it into the chat. Get more information, okay. What kinds of information do we need to get? Evaluate the severity and the likelihood. Okay, actions, okay, things are jumping around on me. Actions that indicate or suggest they're a risk to self or others, okay. So what are those actions?
Jackie, I put a note that Kristen a little earlier put in an answer that also fits here. Past history that might be known, and the person doesn't have supports.
Yes, absolutely. Baseline. Do we know how the person usually behaves? And are they behaving differently now? PHQ-9. If we have the availability of assessment, that may be one option. Plainly ask if they intend to harm themselves or others.
Related to that is a point
yeah.
Jim has, it's related to that. So if you ask and you get details and the person seems to have a specific plan, that's a big red flag.
If there's a plan, access, or prior history, excellent.
Yeah.
Kathy says past history, information from others. When you're talking to the provider, are they currently using substances? Yeah, I know in a lot of cases, and I know in some states it's upward of over 90% of cases of a suicide or homicide, there's substances involved. Okay. Thank you, everyone. Next slide, please. So first of all, what is a behavioral crisis? And how is that different than a behavioral emergency? because the two are often confused. So experts tell us that a behavioral crisis is a serious disruption of the individual's baseline level of function. Someone earlier said something about baseline, such that the person's usual coping mechanisms are inadequate to restore an equilibrium or return to that baseline. It's an emotionally significant event in which there may be a turning point. And another definition for crisis is a turning point, for better or for worse. Now, it doesn't imply necessarily that there's a danger of serious physical harm or life-threatening danger, but it can. Okay. Where in the behavioral emergency, there is that immediate danger of serious physical harm or life-threatening danger. Okay. Next slide, please. So when we intervene, those responses are different between the behavioral emergency and the behavioral crisis. In the behavioral emergency, you have an immediate response, you have an imminent risk, and there needs to be management to prevent that harm or death. This is where you look at hospitalizing someone. There needs to be a resolution of the immediate risk within a single encounter. You know, that's a lot harder if you're on a hotline and you're not right there with the person. So the intervention for a behavioral crisis is usually within 24 to 48 hours, and you develop a plan, whether it's therapy or a way to help, whether it's an individual or the community, cope with what's happened. And you usually see a resolution within 4 to 6 sessions. This is more like I was talking about a community shooting, like the football game on Friday night. Next slide, please. So first fun thing, we're going to have a word cloud.
Yes. Oh, sorry.
Sarah is going to explain to us what that means.
Yeah, so you can all either use that QR code or go to menti.com and enter the code you see on the screen, and then you can answer the question. So there will be some slots where you can share what behavioral emergencies you have experienced in your community. And I'm also getting a link here that I will add to the chat box that you guys can use as well if that's easier.
A question, Sarah, if they want to enter more than one, do they enter each one separately?
Yes, so there will be multiple lines and they can enter each one separately on an individual line, and then you can press submit once you have everything you want added. And I just shared a link in the chat as well. So I will give everyone just a moment to access that, and then I will share the responses that we're getting.
All right. So what we want you to respond to, what client behavioral emergencies have you dealt with as a counselor or that has impacted your community? So you remember the emergencies are those imminent threats. All right.
So you guys can continue adding. Sorry, Jackie.
Yeah, suicide's really the biggest one. And shooting is becoming more and more common. But we see various types of shootings indicated also. Self-harm, different types of self-harm, overdoses, domestic violence. Things keep moving around and I lose track of them.
Probably shooting is a close second. They get some individual clouds.
And the various types of shootings added into that, yeah, it would probably come in a second.
Yeah.
And we're hearing of more and more shootings every day.
Yeah, I
All
bet
right.
20, 30 years ago, maybe we wouldn't have a word cloud like this with so many shootings in it.
No, I don't think we would have. I think that started with Columbine.
Yes.
And for some of us old duffers, as a friend of mine calls us, we remember Columbine.
I still remember where I was when I heard about it. And we talked about it with my colleagues at work for days.
It was just such a,
Yeah, rare
it never
outlier
really
type.
occurred. It was kind of like the Oklahoma City bombing. It was something that really didn't happen every day.
So my colleagues were all psychologists, and we just kept going around and around. What led to this? How could this have happened? What were there warning signs? How did the parents not know? All kinds of classic questions. Everyone, and we didn't have answers.
And Kimberly says she lives in Colorado and they still remember it, and they were locked in their schools after it happened.
Yeah.
So lots of things change as far as, and it's more defensive as far as the things that change, not necessarily preventive. All right, are we ready to move on to the next slide or the next word cloud? I believe there's another one coming up.
By the way,
Yes, I will get that added.
just one
Okay.
note, Jackie and everyone, substance use gets a decent prominence in our word cloud. One could, as you noted earlier, one could make a case substance use might be implicated in most all the other words.
Again, it's
contributing
frequently associated with, to where as we mentioned earlier in the introductory part, that impairment, when they're impaired, they're more likely to do certain things.
Exactly.
And Brian says there was a shooting last week close to my house at a restaurant with a man, an ex-cop who came in, shot his ex-wife, friend, and 8 other people before he was shot by officers. It's traumatizing for the community. Absolutely. Okay, Sarah, here, put the link in. We're going to do this one the same way. What client behavioral crises have you dealt with as a counselor, or that has impacted your community? Now, can we differentiate the behavioral emergency from the behavioral crises?
And people can access this word cloud in just the same way. You'll just use a different link or a different code.
Give you a few minutes to get that, start entering that in. Yeah, they were filming or videoing the football game last Friday night when the shooting happened, and you had people running and falling on the field and all kinds of things, and they're showing that on TV over and over, and that's just re-traumatizing for people in the community. Death of a child, a spouse, unexpected suicide. Is suicide ever expected? Sometimes I think it is.
Yeah.
Homeless encampment sweep. Lack of housing, social withdrawal. Death from child abuse, substances, anxiety, depression, grief, breakup. Addiction. Holly, yeah. Katie? Did you have something to say? No, okay. All right, I guess there are a lot of crises out of there. Behavioral crises that people see. Interesting, homelessness is getting bigger than suicide.
Yeah.
And domestic violence and addiction. Those seem to be the big four. All right, let's move on to the next slide. Okay, so now I'm going to talk a little bit about a clinical response, and the focus of this section will be with suicide as the example that we're going to use. Next slide, please. Okay, so some of the general issues. Whenever there's a behavioral emergency or crises, we often require that counselor who's dealing with the person make decisions that can have long-term emotional, ethical, and legal repercussions. And it's rare, but a counselor can be held liable for negligence if a response is found to be substandard. And so that's where it's really important. We call it risk management, as far as how you fill out your records, how you discuss what happened, what you saw, what you heard, everything about the encounter with the person and what you did and how that was followed through on and things like that in your records, so that if anything happens, you can come back to that and show that you followed a very planned response according to what is expected for those situations. Many times when you're training, I know when I went through graduate school, never once did they talk about suicide, which I found very stunning. It was something that, you know, instructors even weren't comfortable talking about. So that was something that, as I became a faculty member and a supervisor, I made sure we talked about with all the students that I worked with, and developing a mentoring model where you have a senior counselor and working with a junior counselor, that they can be there and kind of help them through it. They can model it for them, and also good supervision, where the junior counselors have someone or others have someone that they can go and talk with to process through situations that may come up in their sessions. Next slide, please. And we talked a little bit earlier about how you estimate the risk of it being a life-threatening behavior. So we think in terms of predisposing or distal risk factors, acute or proximal risk factors, and protective factors. Some of the distal factors are the traits and circumstances that make the individual vulnerable. Proximal or closer to the time of the life-threatening behavior. And protective are those traits and circumstances that protect against those negative behaviors. And it's really hard to predict these rare events, such as suicide and homicide. My tendency is to err on the side of protecting. And that sometimes is very upsetting for the counselor. I remember having a 13-year-old that was carried from my office to the sheriff's car in handcuffs. for them to take him to the hospital. And he's screaming and yelling, and it was very upsetting to everyone around. So it's really hard to be precise in this type of situation.
Jackie?
Next slide.
Quick question, Jackie. Your good points remind me of the challenge of trying to predict rare events. But do you think it's easier to, or maybe there's more accuracy among clinicians to predict someone's suicidal nature or suicidality versus their homicide potential? They both are rare and tough, but do you think clinicians are a little better at one or the other?
I'd say they probably had more practice with the suicidal self-harm than they have with homicidal.
Yeah.
So most clinicians are probably a little better at picking up on the flags for something like that. What's your thought?
Yeah, I agree. They're both rare, but probably homicide is more rare. And to the extent that you get training or supervision on these two topics, it's probably you get more of it on the suicide end of things and maybe not as much on the homicide. So there's even, not as much knowledge or alertness being built in trainings or in our clinical work. So we're perhaps even less equipped.
Okay. Next slide, please. So another discussion in the chat box or unmute. We'd love to have someone unmute and add to the discussion. What's available in your tribal community with respect to a mental health crisis phone lines or crisis response teams or law enforcement response to 911? Do you even have 911 in your community? Because I know some tribal communities, they don't have that. It really,
Ooh,
yes.
Valerie.
Yeah, thankfully we do have a mental health crisis phone line. We have a few different gateways to that. One with our WISE team, and one is a crisis outreach team. And as we're growing our WISE team, I guess we'll see how things play out with having two crisis lines internally within our behavioral health system. And we also have 911 law enforcement, and
Good.
that's good, but that also connects to the victims as well. So then there's the victims of crime line, as well as we have a law enforcement team within our community.
Okay. Where are you located, Valerie?
Oh, I'm in the Lummi Nation in Bellingham, Washington.
Okay. And do you have 988 up there?
We spread the message for 988, yes. So there was, of course, those other external partners that we also utilize too, in case it's after hours or weekends or things like that.
I just wondered how that was spreading into the tribal areas. So thank you. And Marie says that 911 and asked for the crisis team. They send 2 people from Alaska Behavioral Health to meet them where they're at. That can be good, having a face-to-face. It can also be dangerous. And especially up in that rural and remote areas in Alaska. They have Careline also. Leslie says we have 911, access to Northern Nevada Mobile Crisis Unit, Nevada Warm Lines that offer general support for anyone who needs support, and law enforcement will respond to all 911 calls. Are you spotting some others, Ken? They're flipping past.
Yeah, no, Joyce mentions they have 911. Valerie talks about 988, which if people aren't familiar, that's really just general mental health support, not necessarily a critical emergency.
Suicide crisis line now.
Oh, okay.
Okay.
Excellent.
Kaylee has her hand up.
Yeah, I was just gonna mention that here in Southeast Alaska, our tribe has been working really hard to grow our behavioral health services. We have our medical consortium called Search, who it's so difficult to get in to see somebody or even talk to somebody that the tribe has been actively trying to grow their services in different areas, and they have the 988 here as well, and they also have a hotline for our medical clinic as well. So there are a few different phone numbers. They're actively working on getting more people into working in our behavioral health department here as well.
Wonderful. Thank you, Kaylee. Okay, Miriam.
Hi, my name's Miriam. So I just inserted a link. I work with Great Plains Tribal Leaders Health Board in our Circles of Care. So I'm in community behavioral health. I'm the program coordinator for Circles of Care. And our whole mission is to kind of assess and look for barriers in accessing mental health or any type of resources that our relatives cannot access because of barriers within there. And we have within our building, we have a connecting with our youth program. So if you click the link there, you can see kind of like what they do. Currently we are waiting to hear back about our 988 grant that we applied for. So we actually will be hearing back about that by the end of this week as well. But we are located in Rapid City. So we sorry, no caffeine. We work more with urban Indigenous population. And a lot of the Indigenous population here has come from the reservation, which is about an hour and a half away from us. One reservation, there are multiple reservations within this area, but that just happens to be one that most of our Indigenous population comes from.
Okay, thank you very much. All right.
A lot of people are weighing in, Jackie. That it's encouraging. You know, a lot of 911, 988, and other systems.
And I think you see the commonalities and also those areas where there's differences in what's available in certain communities. And so you have to work with whatever you have in your community and how you make that work. And we'll talk about that a little more. Next slide, please, Sarah. So now we're going to shift our focus on suicide and talk about suicidal ideation and their behaviors. And it's very likely that those working in behavioral health are going to encounter a patient, client, or someone in their community or family who's suicidal at some point in your career. A study in 2000 by McAdams and Foster said 23% of professional counselors that they surveyed experienced in their career at least one client who committed suicide. Rather than committed, we like to say completed suicide. Sorry, Ken.
No, it's a good point.
It's language issues.
Yeah.
Communicating suicide.
You'll want to write to McAdams and Foster also. I mean, I think it was their language.
Well, and it's changed. It's
Yeah.
really changed over the years as to what language we use. And a lot as far as how you word things in press releases and media and things like that. So, and I would guess it's even higher now.
Yes.
The number
and the percent that have a client who's attempted. What do you figure?
Absolutely. I would say
much higher.
attempted, it would be probably upper 80s.
Yeah, I mean, it'd be rare to go through a long clinical career and not have.
Yeah, I think possibly, you know, like university counseling centers may get through them, especially in Indian country. I think it's really high for most providers to have encountered a suicide, probably closer to 100%. Okay, next slide, please. And then suicide was among the top 10 leading cause of death in the United States in 2020 for people 10 to 64 years of age. I think it's usually like number 2 or 3. No, it isn't. As far as covering all causes of death, and the health issues come in above those.
Yeah.
So it's around 9, 8 or 9, I think then. The second leading cause of death among children and adolescents. That's what I was thinking of. From 10 to 14 and 25 to 34. So are 15 to 24-year-olds not completing suicides?
It would not apparently fall into second leading. It must be a little lower on a list. I'm wondering if
Okay, it was just interesting that it's that gap.
What do you think's going on between 15 and 24? I was wondering if it's the deaths are more accidental deaths or due to substance use, overdose, kind of stuff, perhaps. Car accidents, those kinds of things when you hit those late teens.
I think there are probably other things that come into play because of less supervision.
Right. Oh, Kathy weighed in. The issue of gun use or the violence due to guns. Yeah. I mean, in some urban cities.
Joyce says they may not be recognized as suicides.
Right. That's a good
point. Lot of one-car accidents are not recognized as suicides.
Right.
So during that period from 1999 to 2020, the overall suicide rate peaked at 2018 and then declined from 2019 to 2021. This is overall. This is the whole U.S. population. This is not just American Indian, Alaska Natives. That'll be important when we move on. Next slide, please. Okay. Some of the variables linked to suicidality among all ethnic groups. If they're male, they have a higher rate than females. Overall, general population, 45 to 65 is now the highest rate. It used to be over 65, but it shifted a little lower now. But this is not the way it is for American Indians and Alaska Natives. Presence of mental illness, depression, substance abuse, schizophrenia, those types of things. Persistent feelings of hopelessness. Or the presence of a substance use disorder. I think I mentioned earlier that in some states, I know I worked in North Dakota, and it was like 95% of the suicides, the person was impaired, either drugs or alcohol in their system. A family history of suicide. And for adolescents, conflict in the family or the breakup of a relationship are real indicators. Next slide, please. And Kathy says co-occurring disorders as well. Thank you, Kathy. Okay, now we're going to talk about American Indians and Alaska Natives. They have the highest suicide rate compared to all ethnic groups in the United States. From 2000 to 2010, suicide was the second leading cause of death for American Indian and Alaska Natives from 10 to 34 years of age. So although the general population, it's up higher, for American Indians, Alaska Natives, it's in lower ages. The suicide rates increased nearly 20% from 2015 at 20 per 100,000 to 2020 when it was 23.9 per 100,000. And that compared with a less than 1% increase in the overall population. And the rates for American Indians and Alaska Natives under 25 are up to 6 times higher than for whites of similar ages. So it's a much higher risk within our communities. Next slide, please. Here you can see that a little easier. And if you'll look, this is from 2011 to 2020. And The only group is the blue line is American Indian Alaska Native, and where even the others around 2019 during the pandemics decreased a little bit, American Indians, Alaska Natives increased. And I think it's Black and Hispanic were the only other ones that didn't decrease. They kind of stayed constant through there. But it helps you see just how much higher and greater risk there is in our communities. Next slide, please. So then it's not just the completed suicides. It's estimated that there are 30 attempts for every documented completed suicide. So I forget what year it was, there were 47,173 suicides. That translates to almost 1.5 million or 1.4 million attempts at suicide in that year. Next slide, please. So when we compare American Indian, Alaska Native, and non-Native decedents who committed suicide, the Native have higher odds ratio of relationship problems and substance use problems, and lower ratios of mental health problems and history of mental health or substance use treatment. So, especially around substance use, there were more problems in those areas and less treatment. Something most of you probably already knew. Next slide, please. All right. Ellers and colleagues in 2022 surveyed 447 adult natives with a mean age of 33 from several reservations. 20% reported lifetime experiences of suicidal thoughts. 14% reported suicidal acts, including either a suicide attempt or verified death by suicide. I'm not sure how they can report a verified death by suicide.
Perhaps coroner made that distinction.
Well, but if they completed the survey, it depends on how the question was asked.
Yeah, I think, did you know of someone?
Okay.
Wouldn't necessarily be personal.
I would think in Indian country, it would be much higher.
Mm.
At least the tribes that I worked with, and even neighboring tribes, if something happened, they knew the people. Suicidal thoughts were significantly associated with a diagnosis of PTSD or an experience of assaultive trauma. So it's high, but I would expect it to even be higher.
I wonder,
Okay,
Jackie, if the mean age is 33, they might not have assessed enough younger people where it's just a much higher rate. And thus maybe we're getting numbers because it's kind of a mean in the middle.
Well, and they're adults too, so they're all 18 and over.
Yeah, exactly. Yeah.
Okay. All right. See, when you get the research, you've got to question these things. How did they do it? How did they write the question?
Context.
All of those things can really impact, what's reported out. So when you get us researchers on here talking, you get all kinds of discussion. Next slide, please. All right. When we look at another article that was published in 2022, they reviewed 45 articles of the most robust predictors of suicide attempts: substance use, depression and hopelessness, violent or childhood maltreatment, violent victimization, and friend or family member who's had a death by suicide. So when you talk about looking at what the risk factors are, those are some of them. For Native youths, significant predictors: risk-taking behaviors, substance use, gang involvement, family conflict, and I would include the breakup of relationship and negative experiences with their school environment. And yes, Kathy mentioned co-occurring disorders, and Elizabeth mentioned ACEs. And I think that's where that childhood maltreatment comes in, or with ACEs.
Right.
Thank you, both of you, for those.
Jacque,
Next, yes.
the list here of the robust predictors and the youth predictors, they're not dissimilar from the general literature, but some of them maybe are more specific to Native individuals and Native youth. I don't know if I've ever seen negative experiences with school environment on a risk list in the general suicide literature. So that might be something.
Or bullying or assault.
Right.
A lot of those things occur in our Native communities. Jordan's asking, were systemic factors considered when identifying these predictors?
Not sure. That might be a chance for us to follow up that article and see.
And then Kathy.
Yep.
Kathy was commenting trauma related to loss and grief, COVID effects, health-related issues due to ACEs, accidents, and bullying.
That's an excellent list.
Mm-hmm.
David mentioned bullying as well.
Uh-huh. Next slide, please. Okay, now it's your turn again. Share in the chat box or unmute and just join the discussion. Research has identified several variables that are risk factors to suicidal ideation and suicide. What do you think are the factors, the risk factors for that suicide and suicidal ideation?
Didn't take long for David. I think he put bullying in his.
Uh-huh. I think lack of family support.
Yeah.
Early childhood and mental health services on Native reservations. Loss of culture.
Yeah. Generational trauma related. Family
Substance
issues.
abuse.
Isolation, abandonment.
Unsafe living conditions. Lateral oppression. Social determinants of health. Complex trauma. Expelled from school. Eating disorders. Relationship breakups. Lack of access to care, unemployment opportunities. Unemployment or opportunities for employment, I think is that.
Mm-hmm.
Barriers to self-sufficiency or supporting the family.
Leonie mentions poverty in a related way.
Uh-huh. Yeah, all of those can be factors. All right, next slide, please. All right, we talked a lot about these things. Now you get a chance to get a visual. If you look to the left side, the fundamental risk factors, those are those distal things, biological, their genetic loading, their gender, their race, their age, all of that figures in. The personal and the psychological, you get in the ACEs, a lot of other things, the season of the year, geography. I think that's environmental, and environmental must have dropped off the slide. So some of the proximal factors, those are the triggers when we talk about the final straw that triggered the suicide or suicide attempt. The crisis in a relationship, loss of freedom, whether it's detention or jail, fired from their job or expelled from school, illness, and other major losses in them. So that increases that hopelessness and the contemplation of suicide as a solution. So that's where they really, get focused on that. And then on the right side, you get causes of death from suicide attempts and suicide completions. Poison, usually drugs, guns, hanging, usually listed as asphyxiation. Autocide. You heard of autocide before? I'm thinking that that's with a car and jumping. Okay. Next slide. This can help to just kind of give you a visual. So, how do we go about assessing all of this? Well, one tool that I like to use is called SAD Persons. And this just gives you an acronym for some of the risk factors so you can remember to kind of go through them. Sex or gender. Males kill themselves 4 times more often than females. Age. Within Native communities, 10 to 34 is the peak range. Depression. Those depressed people are more significantly at risk. A previous attempt. If they've attempted before, they're more apt to attempt or complete. Ethanol. Alcohol abuse is very often implicated in suicide. Rational thought, if they're more prone to suicide if they're psychotic at the time. Social network, the less social support they have, the greater the risk. Organized plan, the more organized their plan, the more details they can give you about their plan, the more likely they are to carry it out. No spouse, and this is again for adults, that the greater risk of suicide if they don't have that partner in their lives. And sickness, a chronic physical illness makes them more prone to suicide. Have any of you seen this one before? I know there's a lot of different types of ones out there, but I feel like this one gives you a pretty good overview. David said, yes, he's seen it.
And Jacque, it looks pretty relevant across age groups.
Uh-huh.
I mean, maybe no spouse one isn't going to be all that relevant for one age group, but all the others look.
Absolutely. It just gives you, okay, I need to think about this. Are they male or female? How old are they?
Yeah.
I think that, they used to say, well, males kill themselves more times and females attempt more time.
Right.
And it just has to do with method. That there's more apt to be a rescue with the methods used by females than there are with males.
Yeah.
Males tend to use guns more. Although we're seeing a lot more asphyxiation or hanging with females. Okay. Next slide, please. I'm going to have to get going. So the clinical response to the strategies. Let's go on to the next slide. Oh, we've got some myths and facts. No one can stop a suicide. It's inevitable. That's not true. If people get the help they need, they may never be suicidal again. Confronting a person about suicide will only make them angry and increase the risk of suicide. That's not true. Asking someone directly about suicide lowers their anxiety and opens up the communication. You know, they're many times relieved that someone's willing to talk about it. Only experts can prevent suicide. That is not true. Suicide prevention's everybody's business, and anybody can prevent a suicide and prevent the tragedy. Next slide, please. Suicidal people keep their plans to themselves. Most suicidal people communicate their intent sometime in that week preceding their attempt. Whether it's to friends, family, doctor's appointments, you know, that could be to any or a number. And if people are aware of certain risk factors, they can start to spot those things and open up that communication. Those who talk about suicide don't do it. Well, people who talk about suicide may try or even complete because it's an act of desperation. But if you get them talking about that and what's going on and switch it to problem solving, you may prevent that suicide, yes. Once the person decides to complete suicide, there's nothing anyone can do to stop them. Well, again, getting to have those conversations, suicide's the most preventable kind of death, and it doesn't take much of an action for someone to grab hold of that rope and take another direction. So it's important to ask the question. Next slide, please. So the 6-step safety plan. Next slide. We're having some real problems with the.
It keeps jumping ahead.
Yeah, it's really trying to jump ahead and telling me I'm not going fast enough. Okay, first of all, you want the person to help to identify with the safety plan. How will they know that they need to use it? What do they experience when they start to think about suicide or feel extremely depressed? They need to identify what their warning signs are. Are they thoughts, images, ways they think about things, their mood, their behaviors? And we want it in their own words. There's my voice is going. There is an app that I'm going to show to you later on that will have places for people to fill this information in, and they can have that app on their phone and make use of it. So you as a provider can help them to fill that out. Next slide, please. Step 2. So this is what that individual feels like their internal coping strategies are. What can they do on their own if they become suicidal again? How can they help themselves to not act on their thoughts and urges? And then how likely are they to be able to take that step if they're in crisis? First, what are the things they can do? And they list all of those things they can do. And then you go with each one of them And how likely are they to be able to do that when they're in a crisis? And then any doubts, what might get in the way of them being able to do those things or to think of them when they're in crisis? And then you work through that and okay, what will help them get past whatever that barrier is? And using this problem-solving approach to address those roadblocks and kind of role-playing all of those things through as you go. Next slide, please. Step 3 are the social contacts that can help to distract them from the crisis. Who or what social settings can help you take your minds off your problems, at least for a little while? Who helps you feel better when you socialize with them? Ask for safe places they can go to be around people. And ask them to list several people or social settings in case that first option is unavailable. If there aren't places that they can go, if the places are closed or something like that at the time they need them, okay, who are the people that they can get hold of? Remember, the goal is distraction from the suicidal thoughts and feelings. And we want to access the likelihood that they'll engage in that step. How likely are they to do it? What are the doubts? What are the types of barriers? How will they get past those barriers? Next slide, please. Step 4, family members or friends who can offer help. They use step 4 if step 3 doesn't take care of the crisis or lower the risk. Among your family or friends, who do you think you could contact for help? Who's supportive of you? Who do you feel that you can talk with when you're under stress? And make sure they list several people. If one contact is unreachable, they need to be able to try some others. You know, sometimes people have their phone turned off. It's not anything intentional, but it happens. So they need to have more than one. And then prioritize the list, put them in an order that they would call them. And this is where they can reveal that they're in crisis to others. And how likely are they to follow that step? What are possible obstacles or barriers? And how can they resolve that problem and to go ahead and follow through? Maybe it's they can't get a signal on their phone. Maybe the other person can't get a signal on their phone. So what do? How do you what is that self-talk that may come up and how do you deal with it? And role play and rehearse it can be really helpful with this step. Next slide, please. If step 4 doesn't work, we go to step 5. Who are the professionals and the agencies that you can contact for help? 988, 911, your counselors and other emergency rooms, other places like that. Who are the mental health professionals that we can identify to be on your safety plan? Are there other healthcare providers that can be included? List the names and numbers or locations, local urgent care services. Again, you go through how likely are you to do it? What kinds of things will get in the way? How can you resolve that? And you role play and rehearse it. Next slide, please. Making the environment safe. Ask them what means they would consider using during a suicidal crisis. Do you know a firearm, or do you own a firearm such as a gun or a rifle? And what other means do you have access to and may use to attempt to kill yourself? Have them identify those things. I once had a 16-year-old that laid out 5 different plans she had to commit suicide. And every time she said, and if you take that one away, I've got this one. If you take that one away, I've got this one. And I was ready to hospitalize her right then. She had more plans than I could come up with solutions. So collaboratively identify ways to secure or admit or limit access to any of those lethal means they have. How do you go about developing a plan to limit your access to those means? Can you get those guns to a family member to keep for you while you're feeling this way? Can you, what other things might you do? Can you make sure someone has your keys so you can't drive your car during that time? What do you do to make sure you aren't using substances during that time? Whatever it is that they bring up, you ask them to come up with ways to limit their access to that. Next slide, please. Ken, were you going to say something?
No, it's just you brainstorm with the client, use your common sense, clinical knowledge, and have that person help with the answers. Because if it comes from the client, even though you know the right answer, it probably makes a bigger impact on that person than if you're just giving them the list of things.
Kathy says, just a thought, substance abuse is a strong indicator for suicidal ideation, attempts, plans, etc. I think this plan can also be used in the context of preventing continuing use or prevent a relapsing event that might lead to a suicidal ideation event, particularly with co-occurring issues. Excellent, excellent thought. Thank you. These are the two suicide prevention mobile apps that I would recommend. The Suicide Safety Plan and the SAMHSA Suicide Safe has the Safety card. And Safety is an acronym, and right now I don't remember what it is. Next slide, please. So the Suicide Safety card, I've got a screenshot there that Safety Plan is an app that the patient can download or you can use. You can have on your phone, and you can help to go through each of those 6 steps that I gave you and set them up. Next slide. This is the mobile app, and this is one also that you can have on the client's phone or your phone, and you can have enter those different things in there. Warning signs, coping strategies, reasons to live, contacts, places for distraction. You can also find support, 911, helplines, urgent care, those emergency contacts, those you can put into there as well, to where they're right on their phone if they need them. Next slide, please. There's some resources here, and I don't think those were in our resource list, but I think we need to include this one and the next one. Next slide. On the videos or YouTube. Oh, these are programs. Next slide. There's the videos. I think those 3, it's important to include in that resources. Next slide, please. Okay, I'm really going to have to go fast on the crisis team. Okay, next slide. Okay, a crisis and recovery or resilience team is a group of people trained to facilitate and mobilize resources in an emergency situation to help stabilize and recover from trauma and better deal with future emergencies. So this is for shooting events, bus accidents, other types of crises in the community, shooting at the football game, all of those types of things. Next slide, please. First of all, it's an opportunity for those local people, say in that school district, that may have some event going on in their own lives, to be able to step back because they emotionally can't deal with it. Maybe they were very close with that child that died. They need to be able to step back and not be in their role, during that crisis period, and you've got some other expert backup that are able to step into the trenches and help provide support, confidence, and debriefing to help those in the community deal with the situation. Next slide, please. The resources, you know your own local resources. You have someone come in from outside, they may not be able to refer to your local resources because they don't know what they are. You're more available in your community. You know and utilize that local expertise, and they're available for follow-up, where a lot of times these outside resources will come in for 1 or 2 days and then they're gone. And you don't have anything after that. So you have counseling, you have in-service trainings, you have support for those in the community providing the resources. Next slide, please. The lack of local resources in the rural and tribal areas, you don't have the mental health professionals, the communications to deal with the media, hospitals and clinic services, programs to support youth, emergency needs. I got called out on a number of mass shootings when I was up north. And it always happened around Thanksgiving for some reason. I don't know why. It was always right around the Thanksgiving break. And someone would come out for a day or so, and then they'd be gone. And the whole Thanksgiving holiday, the kids are out of school and everything, they didn't have any resources to help. Everybody was off on holiday. And I would end up going and staying that whole weekend, mainly because I didn't have family up there and I could be free to go up and do it. But you need to have someone. And then they started referring all the calls to me. They referred the media to me. They referred the emergency first responders to me and everyone else to take care of everything. So you need to build up some of those local resources and train some of those local people to be that emergency response, because that outside person can't stay there long term. I know sometimes we get, like with IHS, they'll get their crisis teams to rotate in on like a 2-week cycle. You know, that's just for emergency. That's not a long-term solution. So some of these things can be helpful. Next slide, please. Again, the local resources, but you get expert consultation, you know, from someone outside that school district, say, as to why they don't have an assembly, why that's important not to do, how to keep students in small groups, what you need to do in terms of support personnel, who's going to answer the phones, who's going to keep track of what are rumors and what's the truth, you know, all of that information. And when I say experts, they can be experts in all kinds of things. I know the first time we developed our crisis team and called it out, there were 3 cheerleaders that were killed in a car accident. And we were dealing with all of that. But the one that came forward that we hadn't expected was the daughter of the man that was driving the car or the truck that hit them. And the guilt and all that they felt around that. And how to, you know, some of those experts are going to be able to access extra help as the community recovers. Next slide, please. Anytime you want to jump in there so I can breathe, you know, feel free to. So when you develop
Jacque,
it, yeah,
I mean,
Ken.
one thing, we could also review a lot of this about the crisis team at our next session in 2 weeks.
That's true.
Feel free to, you know, maybe go a little fast or even skip a slide or two. We have 5 minutes to go.
Right.
But we'll revisit.
And I think we're getting close to the end.
Yeah.
But
Yep.
when you have team members, they're expected to receive the training that you provide, assist in developing the structure, practice the procedure, meet periodically, be willing to respond when they're needed in a crisis, and assist in promoting the team. Next slide, please. And then there are a number of different roles that people can fill. Like I said, They can be a coordinator. They can be the person that answers the phone, rumor control, crowd control. Taking notes. You know, I know when we went to Red Lake, they said that the way they were able to identify the kids that had been shot there were by their clothes. The parent may not know what they wore to school that day, but they knew their shoes, and they could be identified by their shoes. That's what they had to go on because they didn't have IDs on them. So you can be helpful in taking that information from those parents. There are lots of different things that can be done. Next slide, please. This is kind of the flow chart on how the crisis team works. So there's a crisis, and then, you know, that organization responds. They may contact that crisis and resilience team coordinator, who contacts the team, and they go and respond. Then there's a debrief to say, okay, how did things go? We evaluate, we adjust, and there may be a further response, or they may utilize that in future responses. Next slide, please. Again, some more links. Next slide. And summing up, that's all the things that I covered today. I hope you buckled in before we started because I flew. Next slide, please. And I think we're going to skip this one and go on to the next one. And there's your evaluation information. Thank you, everyone. And if you've got questions at all, remember the fourth session, we're going to address some questions. So feel free to send them in, put them in your comments, and we'll try to get to them as we go through in the next few sessions. Ken?
Just want to remind people, we will send the slides that had several important resources and links for you as a follow-up. So, and a reminder, as Jackie said, either send us questions now or hold them and join us when you have an opportunity to connect with our upcoming sessions. And that last one is always a chance to look at the big picture of what we've tackled and get great discussions going and insights from you along the way.
And in addition to some of those resource slides, the app slides will be included in that list of resources as well that we send out.
Exactly. Monica,
it took me years to take together all that information. So you're condensing years of experience into the last year, hour and a half.
Well, it was, as you say, it was helpful if you buckled up at the start of this. But it had some good games and exercises, and you all weighed in. The comment boxes were outstanding. Monica, I'll let you just remind people about the evaluation, and you can close it up.
Yes, please take a few moments to evaluate this session. We really, really appreciate feedback from you all. I want to remind everyone on our second event in this series, Tuesday, September 12th, same time. Topic will then be select clinical topics with helping clients deal with a crisis. We will send out some of these resources in the follow-up email, so please be on the outlook for that. And thank you so much for coming today. Thank you to Dr. Winters and to Dr. Gray. And thank you so much to Sarah for her excellent support today. And I hope to see you all in 2 weeks. Thank you.